you can come, but then we need to have some time, and we need to really give targeted approach to those practices to know, is that some kind of things happens to them, contingency plan fail, GPs are unwell or stuff. So we need to buy some time, because remember the Christmas festive is coming from the next week, and then New Year. So we really need some time to reflect on that. Somebody suddenly turn up. So I want this meeting to happen next week, because I don't want any surprise by next week. So that's why I asked the colleagues to really whether they can join this kind of meeting with us, LMC, CCG, and NHS England with CQC, whether we can delay this process in a kind way the patient care doesn't compromise. Any question?
Nadeem, thank you. There's quite a lot in the chat.
So that's fine. So Sheetal was asking about the face-to-face. So it's about the data really. And Jenny, happy for you to come in if needed, because the data and the validity is quite important here. Is the face-to-face percentage of 20%, is that for GPs or healthcare assistants and other staff?
Less than 20% face-to-face. It doesn't matter whoever it is. It's a health professional. Less than 20%, that's the red flag.
Okay.
And your conversion rate should be 40% at least. When I say conversion rate, the telephone consultation converting to face-to-face or video.
Okay, and it was just saying that in terms of working from home, does that apply to GP practices?
So as long as somebody is available in the practices, is that, look, as I said, it doesn't matter how we do it, as long as patient agrees. What CQC doesn't want to find out from NHS choice, I wanted to face-to-face, and JP gave me a telephone consultation or video consultation, which I find is not really acceptable, because he could not see my rash properly. Those kind of things.
Can I just quickly add, so it's Anil here, that we need to be just pushing forward that face-to-face is the default, and therefore all our staff should be working from the practices, and that's the big push that we should have, and that's what NHS England are sharing with us on all the groups. So we really need to get that message across today to our clinicians, that it is a work from practice, but by exception, if you have a medical issue or something, you'd work from home.
Thanks, Anil. Is video consultation considered face-to-face? Bob was asking. It is. Okay, well, it makes sense. And Anthony's manual was asking about shortage of appointments. Are we talking about contractual obligations or meeting daily demand? I don't know if Jenny might be the person for that, or whether Sabir can answer, because demand is probably outstripping supply everywhere, really. I think you're on mute, Jenny.
The key thing is that contractually practices should be open from 8 AM to 6:30 PM, Monday to Friday. And by open, we mean telephones on, doors open, reception open. So long as you're meeting those requirements, I know that many practices, if not all of you, are using online consultations to good effect, and that is a good triage method. But what we get enormous amounts of complaints about is when somebody, gets told there is absolutely nobody at the practice to see them, and they present at a practice and they can't get past the front door. And that's actually quite a difficult situation to defend.
Do you mean not even getting hold of reception staff, you mean, or a clinician?
Yeah, no, we've had complaints from MPs, councillors and patients where even if they've spoken to a receptionist, the receptionist has said there is nobody here to see you.
Okay, all right, thanks for that, Jenny. I think that's all the questions in the chat bar. So Wax, and then
no, sorry, I had a question.
But I mean, Wax has got his hand up. Just you can come in after Wax. Is that okay? Okay. He's got his hand up.
Thanks, Nadeem. So, Anil, I'm really worried about what you've said about this thing about exception and what's been happening on these groups. I mean, many of us are not party to these groups. If I've got staff who I think can work safely from home and that's not impacting my face-to-face capacity, they're going to be working from home. I'm going to keep my staff safe. Health and well-being staff is of paramount. I want to know what LMC are doing about the ongoing dialogue about CQC, because this is come through the back door again. I'm really unhappy about this. So, Sabir, bless you. You are carrying this forward, but there's a lot of weight on your shoulders here because this impacts practices really, really a lot. You know, those practices that have been identified, where are they going to find the capacity to deal with these visits? Just the thinking of it takes up enough time. OK, so I want to understand what LMC and CCG are doing that, and then also what CCG will be doing to support the practices, because those practices are going to need a lot of support, and, you know, things like maybe even switching off calls to be able to get together to plan for.
OK, well, let's come back. Let's come back to that bit about
Thank
LMC
you.
and Jenny later, but today specifically about CQC. Laura.
Sorry, Nadine, can I just really quickly come in?
And Anil, can you let Laura go next?
Context in terms of what I'm trying to say is that we've got.
Anil, can you let Laura go next, please? Because I mean, and just put your hand up if you need to. I will bring you in.
Please do, yeah.
It's not really going to work if
context, what I'm trying to say.
I know, but we can't have two people talking over each other. So if you put your hand up, Anil, I'll come to you after Laura and Greg. Laura.
Thank you. Yeah, thanks, Nadeem. Yeah, I just wanted to be very clear about the language that they're using about online providers, online consultations, online triage. It's very, very important, because echoing what Jenny was saying as well before, it's not the online triage tool that's a problem. It's potentially people saying maybe things like text messaging, email, stuff like that, and not having that access to face-to-face. You know that we're a high user of online triage, but we have 55% face-to-face GP appointments, so we use it as triage. It's very, very important that we don't have that message across that we shouldn't be using online consultation tools if it works for your practice. Again, that's very, very important. I really think we need to remember that.
Yeah, no, good point, Laura. But I think the point Sabir was also making, that there was a push nationally for online and kind of virtual consultations, and then it's almost hit us in the face later on. But I get your point about navigation and consultations and triage. Greg?
Yeah, thanks, Nadine. I just want to separate two things. The first is the data, the information that the CQC are using to trigger these visits. And the second is what, excuse me, what happens when the CQC get to a practice. Wax posed the question, what are the LMC doing? We met with Andy Ford, who's the Chief Inspector for London, last week, and we had a very kind of honest conversation around the fact that, you know, this is probably the worst time, and the CQC are probably the worst organisation to be doing these kind of visits at the moment. So the approach that's going to be taken, and I'd be happy to have a meeting with the CCG colleagues next week, is not going to laboriously people turn up with clipboards and go through reams and reams of data. It's supposed to be a conversation. I put in the chat bar the areas that the London Chief Inspector has said they will be focusing on. I agree with all of the comments that have been made. This is just the wrong time, and the CQC wading in and allegedly having an intelligent conversation around 111 usage and A&E attendances is not going to help general practice.
No, thanks, Greg. I mean, I think a lot of us share those sentiments about CQC and whether it's appropriate at the moment, but I'm not quite sure we have that much control. Maybe LMC at a bigger level may have. Anil, do you want to come in? Sorry,
Nadia, I think that's what I'm saying. We've had the conversation with the London Inspector. What we will do is we'll follow that conversation up, and we will make sure that the agreement around the focus and the kind of the agenda for the meetings actually gets communicated to the guys and girls on the ground, and actually the inspectors do what has been agreed with the Chief Inspector. So these don't become 3 hours with a clipboard, which is what I'm hearing is happening in some practices.
Okay, thanks, Greg. Anil?
I think we just need to be mindful of our resources and our workforce. So what I'm trying to say is that we've got mixed messages. You're saying see face-to-face, but yet WACS is saying, well, actually patients can be seen online and working from home. And locally, we've got a number of providers who are offering our GPs to leave our practices and work from home 100%. And I'm sure many of us as doctors would happily work 100% work from home. So we need to be really clear what's happening. And locally, I know we've lost a number of doctors to remote online working from home only. So if this is a message that's coming across today, work from home, potentially, how do we then do face-to-face? How do we get that workforce to come and work for us in practice rather than groups like the Hurley Group, etc., which offer 100% remote working at the same rate of pay? So just make it really clear what is the ask.
Yep, fair point about resources and staffing, Anil. So I suppose, Jenny, the question about data, that is 20% face-to-face, the data, and I suppose the kind of validity, because it is quite hard to get accurate data in primary care, isn't it? In terms of we have emails, but we all record stuff a bit differently. Anything you want to add, Jenny?
So a couple of things. I don't know what data the CQC have used to identify the 20% of practices they are going to do these unannounced visits to. In terms of any submission we have made to NHS England in terms of the Winter Access Fund, we have not used practice names at all. We did receive a list of practices, which including one that had already closed. So we were able to challenge the validity of the data that NHS England had sent us in identifying the 20% of practices that they had. In terms of coding, though, and this is really, really crucial, every PCN would have had to do a declaration earlier this year confirming that all of their practices were accurately coding all of their appointments. I'll come to it when I do my my kind of update on the temporary arrangements that we're going to see for the rest of this year. But I think you're on a very, very sticky wicket if your PCN has declared that you are accurately reflecting your appointments as constituent practices, and then you don't do that, because that also forms part of your IIF payment, and it is the basis on which you are monitored by NHS Digital and NHS England.
Okay, so quite a lot of kind of performance management going on, Jenny. I suppose sometimes the issue is it seems to happen a lot more in primary care than maybe outside primary care, and we're in the middle of another wave, it seems, or the start of another wave, and I think sometimes that's the issue with in primary care. Wax, do you want to come in?
Yeah, just a point of clarification. Nobody's telling GPs to go home and work from home or on the phone. What we're saying is, where I've got staff that can, so some of my social prescribers, they're not doing face-to-face, they can do stuff happily at home, online and stuff like that. And actually, that's to keep the staff actually at the practice, who none of us are blessed with brilliant amounts of estate that we can cram people into buildings. We have to be sensible. It's a case-by-case situation, but Anil, 100% not advocating, taking away the face-to-face. But I'm just worried about what's happening on these NHS groups that keep getting brought up, that are giving mixed messages. And I know from a Nell primary care perspective, and Jenny will know as well, that there'll be some very simple guidance coming in the coming days around trying to handle and manage some of this, because it's really difficult for practices hearing one thing and then trying to deliver on the ground. So we'll try and help where we can, and if anybody needs help with that, do email myself or Jenny, no problem whatsoever.
And I suppose on top of that, in terms of CQC support, Sabir is working with Paul at NHC. So if there is any CQC support needed or any visits turn up, then please contact Sabir, Paul or Karen. Anything to add, Karen?
No, I've put Paul's contact details in the chat just in case, for whatever reason, you couldn't get hold of Sabir. But Sabir's already said he's got some allocated time between now and Christmas just for this.
Yeah, we've allocated quite a lot of resource at the Fed for CQC support, and we are helping some practices, I believe. I think. So,
Nadim, can I just say one thing? Most of the discussion will be very confidential, and it will be one-to-one. And some of the GP will get some phone call next week from me, because I cannot really openly discuss these things, and I need to preserve my practices confidentiality. So it will be a peer review. I will just give you the data I have received, and then I will speak to one-to-one, and I will give you all the support, very confidentiality, so it doesn't become a mass media.
Okay, thanks, Sabir. Okay, Wax, quick point then.
Yeah, sorry. So on the CQC point, and we've done, I mean, we do inspections all the time because they keep coming back, but it's all about presentation. So there is not always just everything, is it? It's just about how you present on the day, how you handle yourself. So if practices that are involved in those kind of, these horrible kind of situations, you know, how can they very quickly, within a few minutes, within half an hour of knowing that somebody's here or unannounced, you know, be in that position where they're ready? You know, it's all about presentation. So I think if we could support practices with that, that will be more than 4/5 of what needs to be presented to CQC.
Okay, thanks, Wax. Yeah, Anil, your points are completely valid. Not sure I have the answer, but completely valid points about remote working and the kind of staffing issues we have and the competition. Thank you. Should move on to Jenny. So you're going to give us an update. Have you got any slides, Jenny? You do. So you're happy to share them, are you? Or
I have sent them through to Maggie.
okay, let me just check if Maggie has them.
Have you got them yet, Maggie? Sorry, we hadn't seen them yet. Brilliant.
Okay, so well,
Thank you.
Jenny's just going to give us an update, bit of an overlap with CQC, really, I suppose. So regarding the kind of letters we've received and the negotiations recently, I suspect the COVID booster program.
Exactly. So I'm going to say a bit about the COVID vaccination program and then the temporary GP contract arrangements that are being proposed for the remainder of this financial year. So if we can have my next slide, please, Maggie. Thank you. So there have been 3 key communications that have come out to practices this week. One was on Friday of last week, which was from Amanda Pritchard, the new chief exec of NHS England, and it talked very specifically about acceleration of the COVID vaccination programme as a result of the new variant we're seeing. So the acceleration of the programme talked about offering a second dose of vaccine, COVID vaccine, to our 12 to 15-year-olds, a booster to the 18 to 39-year-olds, and then a 4th dose of vaccine to those who are severely immunosuppressed and have already had a 3rd primary dose. It also talked about continuing with the existing offer that we're making to our residents, so evergreen of 1st and 2nd doses, and we're absolutely delighted to see that every single site is seeing those people who had declined before or were reluctant to come forward before coming forward for their 1st and 2nd doses. We'd also kicked off a programme a couple of months ago around the 12 to 15-year-olds that had started off in schools, but our LVS sites and community pharmacies are also offering that. And then a continuation of what we've done in phase 1 and phase 2 in terms of offering a booster dose to health and social care frontline staff, care home residents and staff, and those aged 40 plus years. Next slide, please. So the other key element of the guidance that has come out this week, and it came out with the national protocols and other vaccine stock information, was an acknowledgement, some might say at long last, that actually what will really help this vaccination programme is for vaccine to actually be available at individual GP practices to allow for those patients who will go to their own practices but won't go further afield to be vaccinated. So we were allowed to move vaccine for designated pop-ups and care homes, and we were moving vaccine as well out to practices when AZ was available. But the most recent guidance this week has said that, subject to a number of requirements, a PCN can move, an LVS site can move vaccine stock out to a GP practice within its designated, that has designated it as its main site. So those requirements are that the LVS will remain open and operational. So this isn't a question of all of the vaccine being shipped out to practices and that's the only way it can be delivered. There is an expectation that the local vaccination site will remain open. All requirements and guidance on the movement and storage of vaccine will need to be adhered to, and there is an assurance and sign-off process both by the clinical lead at the local vaccination site and the medicines optimization team who do that assurance and the sign-off. And the reason that that sign-off is so important is that irrespective of whether the vaccine moves out to a GP practice and is deployed there, it remains the clinical responsibility of the LVS site lead for that vaccine stock. And so both ourselves as the CCG and that clinical lead needs to be assured the vaccines are storing, that practices would store and handle that vaccine appropriately. If we agree then that the vaccine can be moved out to practices, there can be no further onward movement of that vaccine to pop-up sites elsewhere. And in order to ensure that the vaccine then is being deployed within the legal framework in which it's been offered to us and supplied to us, the PCN groupings collaboration agreement would need to be updated to reflect all of those arrangements. So our medicines optimization teams right across NEL at the moment are updating the assurance and sign-off process in order to allow this to happen. If you are interested in actually deploying the vaccine yourself from your practice, then we will be able to confirm to you what the arrangements will be. But please don't start doing that until you've had the sign-off to do so. Okay, so moving on then to the temporary contract arrangements. So that letter last Friday referred to freeing up capacity. And then a further letter was published on Tuesday, and that gave a bit more detail about how that capacity was going to be freed up. So it's going to be freed up in a number of ways I'm going to take you through now. So the first thing to say is that these temporary arrangements will be in place from now until the 31st of March. And the first set of arrangements relate to QOF. So practices are asked to continue to focus on delivering the full vaccination and immunisation indicators, the two cervical screening indicators, and I've given all the indicator numbers there. 19 separate register indicators, I haven't listed those, and 8 prescribing indicators. So practices should continue to deliver those because we're being asked to really focus on those particular areas. So that's VACNIM, register sizes, and long-term condition areas really in the main. 46 QOF points are going to be reinvested in those indicators that I've just been through. It's been agreed that the QI domain indicators will be paid to practices in full, and the remaining indicators will be income protected. Okay, so that's QOF, and then some adaptations to the investment and impact fund as well. So practices and PCNs are asked to continue delivering on the 3 flu indicators included in the IIF. And this is the bit that I referred to earlier in terms of the appointment categorisation. So there is a clear requirement this year for practices to have moved to a position where they are clearly and accurately reflecting the appointments. So if, for example, you deal with somebody on the phone and you decide then that you are going to see them, so you need to see them on a face-to-face basis, you need to make sure that you have coded that you have spoken to them on the phone for a telephone consultation, and also code when you see them face to face. And the reason that is so crucial is, one, it gives you an accurate reflection of the work that you are doing, and that will become even more crucial as we start to work with you on the Winter Access Fund. But also, as PCNs, practices will have declared that they are accurately categorising their appointments and recording them in that way. So you've made a declaration to say that you're doing it. On that basis, NHS England are working on the basis that you've completed that piece of work and it's now business as usual. And therefore, you do really need to make ensure you keep going with that and accurately code all of your contacts. There will be a new IIF indicator introduced as well, and that will be based on active delivery of the COVID vaccination programme. All practices are currently signed up to the 31st of December. There is an expectation that practices will continue to remain signed up to continue until the 31st of March. No one has come to me at the moment to say that they want to pull out at the end of the calendar year. We did have one PCN in Waltham Forest that never did opt in, so they're being given the opportunity to opt in now. But if any PCN is thinking of opting out, can you please let us know really urgently? If I don't hear from you, I'll assume that everything's fine and you're happy to continue going until the end of the financial year. And there will be a kind of IIF indicator that provides further funding to you on that basis. And then all other IIF indicators are have been suspended, and the funding will be repurposed into an allocation, which will be known as a PCN support payment. And that will be subject to confirmation from the PCM that it will be reinvested into services and or workforce. Next slide, please, Maggie. So 3 other key points just to make you aware of. For those of you who do deliver the minor surgery DES at the moment, your income will be protected from the 1st of December to the 31st of March on that. Any activity that you do continue to do in terms of QOF and IIF, please make sure that you continue to code that activity as the basis of your payments will be based on your CQRS entries. And then finally, the guidance talks about practices submitting a plan to the CCG, which needs to be approved in terms of how you're going to deliver these temporary arrangements. What I wanted to confirm to you is that we're not expecting you to submit a plan. We are formally going to write out to you. We are trying to and aiming to take as light touch an approach as possible. So what we might do is ask you just to say yes and no against a very short survey. But we, from a Commissioner point of view, we do need to be able to demonstrate that we have agreed a plan with you in order to make the temporary contract arrangement payments that we will need to. And that is my final slide.
Okay, thanks, Jenny. So Salma's just asking if by coding you mean appointment mapping. I think that's correct, isn't it?
Yes, that is appointment mapping, yeah.
Yep, and I think some of the equip stuff helps with that if you're part of it, the Eden Bridge. And I think the one that Laura was mentioning, which is what's actively delivering the program, is that, I mean, that's quite a kind of a vague.
It's not vague at all, though. It's either vaccinating yourself in your practice, you or your staff or giving up staff to the LVS sites to help them vaccinate. and continuing to do your call and recall. So it's a mixture of all of those things. So it's workforce and full-on support. So the expectation is that because quite a number of areas that I've outlined there are being stood down, notwithstanding the fact that we know that you are very busy at the moment, there is an expectation that you will support the programme by giving by freeing up some of the staff to help support the programme.
Sure, but in terms of making sure we're all doing similar amounts, because I think in the past when there was this kind of involvement and engagement, there was some practice of releasing staff, some were not so much, and call and recall is also active. So in terms of going forward, can we have some guidelines? Also, you know, QOF might have been suspended, but I'm not sure we're any less busy this week, if anything, the other way. So there is that risk if we move staff into vaccination that you could end up with, you know, you have less capacity in primary care. So I'm just, these are my kind of ideas.
Yes, so this will be part of the plan that we aim to agree with you.
Okay. Any questions? Greg?
It's a question that I'm probably not expecting an answer now. Jenny correctly mentioned that the new IIF indicator, which is described as a binary indicator, requires practice to sign up and be actively participating in the COVID vaccination programme. So there needs to be a conversation around what we mean by actively participating, because that is dependent on the ability of a practice to be able to actively participate. And there is also something in the guides which says that if in exceptional circumstances a practice cannot actively participate, then that should not, you know, after a discussion with the CCG, impact on the rest of the PCN. So I just want to flag that.
Yeah.
Okay, and yeah, so is that a conversation we want to kind of start now, maybe, Jenny, in terms of what does actively mean? I mean, I think call and recall, I suspect most of our practices, if we're not doing QOF call and recall, can quite easily translate that into call and recall for our vaccine boosters and the evergreen offer, maybe. You're shaking your head, Wax. In terms of our staff, GPs, nurses and active involvement in the sites, I think that's the part where we need to have that discussion. Jenny, Wax, any comments? I saw you shaking your head at call and recall.
No, I was just looking at a report. No, yeah, on that call recall, it really depends on the practice, doesn't it? Some people are able to manage it, some people aren't. And then tomorrow when the receptionist doesn't come, or the admin team don't come, or the doctor doesn't come, and all of a sudden things get poo-pooed. So we have to be careful what promises we make. There are some things that are out in the system that which should really be supporting. So that's a conversation for another time around call recall. But I think asking practices to really step in there it's not easy. It really is not easy. It really is not easy. I think we just need to be clear, and Greg's right. We need to, just something simple to make it clear what the expectation is would be helpful.
Is that something we need to discuss at the CD meeting, maybe, Jenny, or probably in a few forums? Kavita can come in.
Well, we could do, I think, let's turn that round to the site. So we've got several representatives on here who are actually running an LVS site. And the whole point of this is to support you as LVS sites deliver this programme, because it's you that is receiving the stock. And our uptake is slightly adrift of where we would want it to be. So what would be your expectation as an LVS site when we talk about active involvement?
Sure, that's fine. And the other thing is, I mean, there's extra resource, isn't there, for vaccination till the end of March, I believe, an extra £5 and £10 for housebound and care homes, which I think goes back retrospective, doesn't it, to the booster. So there is some extra resource for additional capacity. But coming back, and sorry, Kavita first.
Yeah, so I mean, just giving examples of, there's 3 or 4 things that we've done. So we've actively tried to support around calling those vulnerable cohorts, Jenny. So the 12 to 15 CEV, then our remaining sort of CEV cohort, that does take a lot of time in. Some of our staff are helping at some of the other sites as well. So and that's been going on for over a year. I think there's a couple of things we mentioned on another call earlier on the week about opening up the PCN boundaries. I think that's important because that makes it even easier and much more convenient, especially when we don't have coverage across the whole week. That I think would be the #1 thing that would make the biggest difference. And then actually those practices who are in the PCN and not delivering, maybe buddying up or supporting where they have, when they have challenging times around call recall as well. So it's those kind of things. Some practices have more GP capacity, some practices have more admin capacity, and the calls are quite specific, the cohorts are quite specific. So something along those lines, Jenny. But I think it really is practice dependent. But that's what we're trying to do here in Newham North kind of situation. And the other thing is with Claremont actually come and do clinics here as well. So rather than us ship out the vaccine, they actually come and do a clinic here at the practice as well at Wood Grange. So that works quite well as well. So that kind of support as well. So some people will be able to do it, some people won't. But if we can get to a baseline kind of position, that would be really helpful and clear for practices.
Okay.
And Karen, what do you think would make a difference from your perspective? Because obviously you're running a couple of sites and all of the housebound arrangements as well.
Yeah, so, and I don't know, I mean, Kavita's waiting to come in as well, but I mean, so we are short of staff, and one of the things we've been doing with the training hub is how do we escalate some more people coming through the training program for vaccination. But also we're short of clinical leads because, you know, the more senior experienced clinical leads, we need someone on site the whole time, especially as we're seeing some of the younger, some of the younger cohorts need that additional clinical leadership and skill set. I do know that quite a few PCNs have been drawing on their ARS roles, social prescribing, some of those staff to do calls and actively support the roving team in particular, who are doing those more difficult, challenging patients, either with SMIs or learning dis or some of those challenges. So I am aware that PCNs are doing elements. Staffing is probably our biggest challenge at the moment.
Okay, Kavita, sorry, made you wait a bit, didn't I?
Not a problem. I was just going to say similar things. Really, is just, in Newham we have a real workforce baseline deficit. So the restrictions they put on and the changes they make nationally, we just have to kind of realise that actually does that work for Newham and Nell, where we're already coming from a very different baseline. So I think it's just about thinking, actually, and having that supportive viewpoint that some practices will not be able to release staff, but they're just not in that position. And I don't want practices to collapse under that pressure and then be penalised, because then they won't be paid IIF in some way. Of course, they should be supporting as much as they should do to the recall, but I don't want us to be in that position. And I want us to be thinking of other ways, like Karen was just mentioning, with the training hub pipelines that we can support in other ways. Now, registered staff is very difficult, but we do have a pool of unregistered. They're ready, they're trained up, they're ready to go. And to have those conversations with the LVS sites as to how we can get them in quite quickly, as long as they're supervised. So that's the kind of points I want to raise, is that actually we always go to this kind of, but actually we're working in a very deep end, hard area, and we need to recognise that and have those supportive conversations.
Okay, thanks, Kavita. Anyone from Essex Lodge? I can see Carolyn's on the call. I know you're running some vaccine
Yeah, so I think the biggest difference will be what Jenny's just presented, stepping down all those indicators. So for us, we use quite a lot of the R's role. We've got the social prescribers doing the recall. We've got 2 health and wellbeing coaches that we've upskilled to be vaccinators. We've leaned on a couple of other practices to get some admin staff over to help us run it. And we've got quite a few vaccinators. But I think the difference is going to be stepping down those other indicators and having an understanding from the other member practices to allow them to be released to help with the vaccine program, really. I think that's going to make the biggest difference for us.
Rima, do you want to say anything?
Yeah, I mean, obviously, as an LVS site, you'd want to try and do everything yourself, okay? Because it makes sense if you can have that structure, but it's so difficult delivering the vaccine and continuing business as usual. And as you said earlier, Nadeem, patients aren't going away. So yes, we've got support with their cough indicators, but actually the patients are still expecting their chronic diseases and all of that work to still happen. So if there is anything that other practices can do to help out, we totally understand the situation, the workforce issue, etc. But it's just a matter of if practices around can kind of buddy up a little bit and just support. We value that, but it is challenging.
Yeah, we need in the next week or so work out a plan, don't we, across the practices and the networks. Manuel, you had your hand up. Anything you want to add at all, or was that a legacy hand?
I just wanted to make a suggestion. I mean, things that I've come across today is about the mandatory vaccination, COVID vaccination for the staff. And with this working from home on Monday, some of the staff are asking, do we need to vaccinate? We can work from home. So we need to factor, if many staff ask that, then adding to the shortage of the existing workforce, that we're going to have a problem. We may have a problem.
Yeah, I mean, it doesn't help, does it, in terms of the rules which are coming in? I think at the end of March, isn't it, Karen, for double vaccination for patient-facing clinicians or staff? Tammy and then Wax.
So I think the other thing to say is about how we're taking the patients along with us with some of the journey. Because today, if I look at my morning surgery, a lot of it was about chasing appointments that they haven't received from secondary care and just that waiting list. So I'm finding it really hard to convert to 40% when actually half of my clinic this morning was about an onward referral that they were waiting for, or just sort of managing that chronic condition. So I think, as we are planning this, we really need to look at the patient-facing comms, because we need to make sure that we're directing patients to where they need to be and actually stepping up the pharmacy message as well. I think that will really free up a lot of time, because potentially, yes, I could have been doing something else, but I wasn't. I was managing the fact that there are so many people waiting for their secondary care appointments. So something about just letting them know what's going on. I had patients who have been referred in October and November, still haven't got an appointment yet. So they are coming back to us, and that's huge workload pressures. So I think it's really important that whilst we're trying to fix our bit of the system, we've got to look outwards as well.
Yeah, so Greg just mentioned detailed NHC guidance is imminent, so that would be helpful, actually, I think.
You will notice, Nadeem, imminent is in quotes. It's the NHS England definition of imminent we might want to think about.
Might be before Christmas then. Wax, last
word.
Yeah,
I just want to just come at this from another angle.
A tangent.
Yeah, well, yeah, my tangent. So for a whole year, we've been trying to do this, help each other, shake each other's hand, hold each other's hand and stuff like that. Let's be realistic of what we can all do. But from the other kind of perspective is that actually, I'm looking at run rates, okay? Where are the vaccines being actually delivered? Where are they actually being delivered at pace and stuff like that? I know Jenny presented a bit where X practice could take a vial, or so that's further down the line. But I think a lot of resource is potentially going into the central call recall team. I know there is a central call recall team. Karen knows, Jenny knows how much resource has gone into that, and actually how is that coming out to support the practices. This is not just about primary care, guys. Public health is everybody's problem. Please stop. I've been living this, breathing this, sleeping this for a whole year. Please, please, please. Another bid went in, £60,000 going to go to voluntary care sector organisations. We need the support where the run rates are good. where it's working. Let's please think about primary care and supporting primary care. And you know, I know Anil, bless him, has been trying to get the call central team for 4 weeks now, Jenny, and we've discussed this, and you know, he's still struggling. He still hasn't been able to get one peer champion to come to his practice to help him with some of the calls. It's really, 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 really difficult. So we need some acceleration on that. This is just not a primary care problem. This is a public health problem. Please, can we get this sorted? Please, can we get some fairness and equity into the system before we get pushed off the edge come April?
Okay, yeah, thanks Max for that. Anything Karen or Jenny want to add? Because I know the call and recall system was with LBN. Was that before April?
Yeah, it's still, so the LBN team still manage the call and recall. I'm really disappointed if that support for Anil's not come through quickly.
What kind of resource was put into call and recall with LBN?
It was 200-300K from what I recall.
Okay, so a big resource. Okay, that's fair enough.
And I
not
mean,
sure there's much.
I suppose the one thing I will say, not that this is the answer because it's an ongoing dialogue, Tammy, is that there was a session yesterday that I joined that the public health team did with all their champions across the borough. A big part of that was around the messaging on track and trace, the new rules around masks, and obviously pushing up a booster and vaccine uptake. So whilst it isn't the answer, I am, aware that they are doing a lot of that communication support. But I think one of the things, and I'll reference it in my contribution next, is how do we coordinate so that at least all the practices know what clinics are open in terms of vaccine, when things are offered, and so on.
I mean, what kind of performance management do they get in terms of call and recall and targets? Do you know, or? I'm not
aware of any.
Okay, that's fine. Thank you for that. Rex, you've got your hand up.
No, I think I've made my point. I think I've made my point on tangent. We need some acceleration with that, and we need help for the practices. A year of promises is gone. No more promises. We need action.
Sure. And I suppose the other point is that if you keep coming back to primary care, the same kind of ask, I mean, it kind of starts losing effect really after a period of time. And in between, you've had kind of politically motivated kind of attacks on primary care, and it doesn't help morale, and it doesn't help, our motivation to work.
Just going to say, Nadine, Helen's on the call, and she's referenced the call handlers. So I don't know, Helen, you might be able to just share the support that's there. Maybe she hasn't got audio.
Fine. It's okay. If you can send us the information in that chat.
No, her mic's not working. Apologies, but she's put stuff in the chat.
No worries. Thank you. So we'll move on to you, Karen and Paula. Paula, who's our Director of Patient Services, to give us an update on the vaccine boosters.
It's actually just going to be me because Paula's up to her neck in UTC and you name it. So I just and we hopefully might even finish a bit early. I just thought we should spend a few minutes just with a little bit of a marking of the fact that we've done a year of this now. So everyone will recall, this time last year, setting up those first clinics. And really trying to get the 80-plus-year-olds over at that time to SLG. So with your permission, I'm going to just quickly replay a video that we did at the very beginning that just might take you back there, give you a bit of a warm feeling, because I know it's been flipping tough going. And then I was just going to do a little bit of an update on where we're at in terms of what we've delivered to date. So Maggie, play the video.
Okay, just bear with me a sec. Sorry, could you hear that?
No, there's no audio at the moment.
Okay, hold on a sec.
We always struggle with the audio. It's one of the challenges we have with these videos.
If there is no audio, I can sing.
Subir will dance and sing. It's a very short video, but hopefully it might just remind us quite where we've come. Oh, we're coming back. I'm just noting the voluntary sector comments in the chat. Shito, just whilst we're waiting for the video to come up, we've reached back out to the Red Cross team again, and hopefully they are going to try and bring some additional volunteer support into the centres. So we'll come back to you on that.
And are you taking any blood thinners like aspirin, clopidogrel?
Ready? Yeah, that's one. That's right. Sharp scratch coming. That's it. That's all done for you. Okay, lovely. Thank you.
That's all done. Finish you. You're very much welcome.
Well, thank you very much.
It's just like having a flu injection. No problem at all.
Absolutely fine. Great. Yes, no problem at all.
Your script.
Simple, no difficult.
It's quite good, isn't it? Better than I expected.
Feel proud of my papa is first.
You might have seen videos like this before.
That's right, Maggie. Thanks.
Anyone can make one of these videos.
Slides. We've got the extra there. So you will recall, if we just move on to the slides, that obviously this time last year it was cold and wet, and at the time we were in the sort of height of the pandemic anxiety, and quite reasonably everyone was nervous about traveling outside and so on. So, you know, it was quite a Herculean effort. And I recall many of you in that basement, well, not basement, in the downstairs room at the Ludwig Gutmann Centre, coming and seeing each other in person for probably best part of a year at that point. And yeah, so it was a great time in terms of feeling like we'd got a solution to what was clearly an ongoing, you know, pandemic, and felt quite futile at that point. So where we are now, a year on, if we just move on to the next one, and you should have all received this, but there was a letter that came out from Nell, Sir Henry Black, John Jagan, and Marie Gabriel, really thanking everyone. And I guess I want to underscore that, you know, and certainly the session we did with the public yesterday was really, really appreciative of the work that GPs have done right the way across the borough. And you'll see in the letter, if you hadn't read it in detail, that, you know, 2.8 million doses have been given, and, you know, nearly 90% across the nail patch, which is really significant in terms of the cover that we've been able to give. And a real massive thank you to everyone in that correspondence from the NEL team, but also I think on behalf of the public. I think that's very much what Marie and colleagues were saying. If we just move on to the next slide, Maggie. So where we're at, sorry, I think one back from that one. That's it. So I've slightly merged a couple of pieces of information here, so sorry if it's a bit muddled. But I put the NEL data on the top left and the Newham data on the top right. You'll know we're nearly at 67% coverage in terms of uptake of the first doses, and just shy of 63% in terms of second dose uptake. Boosters obviously a bit lower, and we're still working our way through. We're not far off what the NEL figures are, which if you know in terms of Redbridge and some of the outer London boroughs, they've got a very different reality to us. And so I think, you know, Newham should feel really proud of the work that it's done, and the volume of patients that we've seen. You know, we've seen so many more than any other borough in the NEL patch. You know, the 300,000 is just an enormous figure that everyone across the borough has been part of delivering. The graph obviously shows you where we're at in terms of each of the cohort segments. I've put the sort of numbers at the top of the NEL averages where we are a little awry, if you like. We're a little off average. So there's still a number of our 80+-year-olds that were just a little bit out of line in terms of nail numbers, I think, and Jenny and others may well be able to reflect that's probably coding as much as anything, and we need to make sure that we're really capturing any issues in regard to proper coding, just to make sure that we really have got anyone, you know, in that sort of frail and older cohort that for whatever reason has been missed. We really need to know who they are so that we can support them to get vaccinated. Similarly, some of the other 75 and 70-year-olds, we're a little lower than the NEL figures. But probably the one I think everyone's keen to really encourage, and you know, if you couldn't do anything much in your practice, but the one thing might be to review your list of pregnant patients. And if you could look at who you know is in your patient cohort and is expecting or breastfeeding, and really try and encourage uptake there, because we know that we've seen much lower uptake in terms of receiving the vaccination. And I think colleagues will know that there have been a number of incidents in terms of young women who are pregnant in the ICU, which is obviously really, really miserable for everyone. So that's the data where we're at, and, you know, massive congratulations across the board. And I guess the next slide, Maggie, gives you a sense of how we've done it. This is data from the last 7 days, but fundamentally what it says to me, and I put the arrows on to show the clinics, the primary care delivered clinics, what it says is it's a real team effort, and every single part of the borough has sites. I mean, you know, who would have thought from the outset when we had our one site at SLG, we would have so many sites aplenty now, and there are real opportunities for people to get their vaccine even if they can't travel great distances. But if you look at the numbers, the volumes of patients are coming through the primary care sites, and that really is a reflection of their trust in general practice. You know, you can see there the numbers that are coming into Westbury Road, into Wood Grange, into Star Lane are higher than many of the other areas, and I think it is a reflection of the relationship that you have with your patients as to how they're coming through. We are trying to, oh, Tammy, do you want to ask me a question now?
It was just about the pregnant women, really, and the breastfeeding women, because obviously we don't have a lot of contact with them if they're well and they are going to antenatal clinic. So I'm just wondering what interventions we're putting in place in the antenatal clinic, because it's really difficult for us to kind of know, are they still pregnant? You know, where are they? And whether that's something that we need our call and recall team or our, you know, one of the clinical leads to really sort of focus on, in that you are literally, you've got a table there and we're having those conversations. I don't know what's happening, but I just think it's a difficult ask of primary care, and I don't want us to be working on something that is really hard and we're not really getting you know, positive results from that, because that's really demoralizing.
That's a fair challenge, Tammy. Jenny, if I remember rightly, the consultant teams were not just pregnant ladies, but also some of the other specialist teams were writing out to their patient cohorts to try and push up vaccine uptake. But did you know anything more in terms of the maternity services?
No, that's right, Karen. I think really what we're asking practices to focus on is if the opportunistic times when patients will come to see you, and particularly by the time they come to see you for their 6-week check, their postnatal check, and and their 6-week baby check, then that would be the time to just opportunistically check with them as well.
And I mean, Jenny, is it something we can follow up with the maternity teams? Because I do know that was the ask, wasn't it, from CCG?
Well, yeah, I mean, it needs to be a kind of a concerted effort. So maternity teams and health visiting teams as well.
Who is our maternity lead locally, Jenny?
Do you mean clinical lead or?
Yeah.
So I think the clinical lead is a joint responsibility between Dr. Venugopal Jr. and
I think is it with Emma, Jenny, who's our
yes,
children.
Emma, that's right.
Okay, that's
Emma does the children's bit.
Okay.
And then Dr. Venugopal he does the kind of the maternity aspect of it.
Yeah.
Okay, thanks. So just in terms of uptake, just a couple of slides that you might have seen, but these are the latest ones in terms of uptake, in terms of different ethnic mix. We know that some of our communities are much less positive about coming forward and getting their vaccines and getting their boosters, and you can see there that we still have lower uptake in terms of the Black Caribbean and in terms of some of the categories of other white. I think the other white includes some of the European communities, so some of the Eastern European communities are less confident and the uptake is lower. But also, interestingly, you can see, so basically it's the pink that you want to be looking at, because the pink line is the people who haven't been vaccinated at all. But, you know, there is a little bit of an uptick in terms of the Pakistan or British Pakistan community that, you know, would be great to get some messaging out to try and increase to reduce the pink blocks, shall we say. But again, I think this is something, and I don't know whether Wax and other colleagues, we've spent a lot of time thinking really hard, reaching out through the various faith communities, going into different messaging, making sure that we have multiple languages around call and recall. You know, I have to give credit to the public health team. They've really tried to make sure that we've brought some strength of offer here. And I think, you know, the borough that we are, you know, the fact that that pink block is there at all is kind of normal, but or you'd expect it, but you know, I guess it's testament to the hard work that's gone in. I don't know, Wax or any of the others, you've been heavily involved in making sure that the offer we make is really appropriate for the borough.
Yeah, thanks, Karen. I mean, yeah, a lot of work has gone into that kind of inequalities kind of situation. I guess for mine is that it's the next step for those who we haven't been able to reach, as you've articulated there, and actually doing something a bit more hyper local with the resource that we've been sort of given to be able to work with that. And you know, I think there's something that we could do. You know, and that will only happen in partnership, though, you know, with our champions and the, you know, the door knocking and the hyper local, geolocal kind of work that they're kind of moving into. It's much more complex, it's much more advanced, it's much more slow paced, but absolutely it has to be done while we've got this evergreen offer going on, and we'll keep on discussing that. We've done everything else. We've got leaflets in every different language under the sun. We've got badges, we've got sites, we've got a bus today. We just need to go to people's doors now.
But Wax, the problem is that the reason why people are not having a vaccination is it's not like a homogenous group. It's natural immunity. They think they've got natural immunity. A lot of our patients, some of them are worried about long-term problems like fertility, chips being put in. So you need an individual kind of a tailored approach, and that needs a lot of resource. And I'm not quite sure that's happening locally. But I think that goes back to call and recall, but that's probably the opportunity we've missed really locally within our kind of diverse community.
Nadeem, I can reassure you all that work's happening, but you know, I would love it if we were blessed with a bit more resource and people power to be able to do it. People power is the real crunch point at the moment. I don't think anybody's going to shy away from spending any money on this. But, you know, there's a hyper local kind of approach that we want to move into and continue and sustain all of the other work that we've been doing. But it's just finding capacity. And, you know, we've just had a conversation with Jenny around call recall. It is really, really tough. But the only way we can do this is sharing the load. And on the bit about the maternity, you know, I think our partner providers have a big responsibility in that kind of situation, because pregnant women are going through the hospital doors on a regular basis. You know what I mean? So, you know, there should be no reason whatsoever. And I've spoken with Vanessa, the relative consultant who's looking after that, and I know she's doing a lot of work with that. And I know Newham have an event, I believe, this weekend, Karen, Newham site have an event this weekend, so fingers crossed. Yeah, absolutely.
So yeah, and you know, there is a lot more to do, but I guess it is important to acknowledge that there has been a significant focus around, you know, how do we do it? And not surprisingly, if we just move on to the next slide, you know, the context of deprivation is also informative, isn't it? And you know, we can see that as communities are in a more deprived context, their uptake is lower. So there is, you know, sadly something quite predictable about what we see in terms of deprivation. I'm just going to move on to the next quick one, just to say, obviously, in the mix of this is the flu uptake, and you know, we are starting to see reasonable uptake in terms of the flu, which I think, you know, I've not been around for multiple years, but from what colleagues tell me, you know, we're starting to see a better uptake of flu. It's still hard graft. I know the teams are still out there pushing it hard, but you know, it just keen to show that the flu uptake is still a big part of what we need to offer and how we're supporting patients. So just, I think Jenny went through, if we move on to the next slide, Maggie, it went through, no, one back, thank you, the changes in terms of your contractual position. But, and I'm pretty certain you all know this, but obviously we're now able to offer the booster to everyone. So the age criteria has gone completely. The reality is we don't have sufficient appointments for everyone to turn up. So we're going out and approaching people in groups in terms of the age cohort. So we've done the 40-plus-year-olds this last week, and we'll be moving our way through the age groups in terms of texting them and sending them messages. I know that most of the LVS sites and all of the primary care sites are also accepting, pretty much all of them accepting walk-ins. And as Jenny outlined, that they've changed the way in which clinics have been supported to enable that. And then finally, just to underscore that the 12 to 15-year-olds are now also eligible for their second dose. So really, for your own understanding, if your reception teams or colleagues are just asking, you know, who's eligible, what's going on, that's the information. The severely immunocompromised are eligible for their booster if they've had their 3 primary doses. So that's one of the other pieces in the mix here. So just finally, and I think what we'll do after today is, in conjunction with the other GP sites, we'll put together a grid for the Christmas period for everyone. But these are the NHC supported activity over the Christmas and New Year. So SLG will be open up until the 20th of December, and then from the 27th we'll have some days open. You can see there that we're going to be open on the Wednesday and the Thursday of what is the week between Christmas and New Year, and the Friday morning. East Ham is going to be open this weekend, and the 19th will be their last day before the Christmas period, but they will open on the 2nd of January. So the what is the kind of New Year's bank holiday. And then Westbury Road are running clinics on Tuesdays and Thursdays through the Christmas period. But what I'll do is I'll put together a grid in conjunction with the other primary care sites so that you can see the full range. And because they can now accept walk-ins, if you have got patient referrals or inquiries, then, you know, I think it's quite legitimate to say, well, you know, our particular clinic's not open, but please feel free to go to the one down the road. So that was it for me, and I'm hoping that it's just a little bit of, you know, feeling proud of what you've achieved and feeling, you know, enormously positive that, you know, the support for general practice in terms of the way in which they've delivered this. I know that sometimes the media doesn't give you the credit for it, but I think the public do. I think the public do know how much their GPs have worked to make sure that the community is vaccinated.
Thanks, Karen. And great work with the housebound care homes, which I know we've done with the practices like ET and First for Health. And we've got lots of sites open now. So we started off with SLG, East Ham, Wordsworth, Woodgrange, Essex Lodge, and recently Caroline's practice, Star Lane, I believe. So we've got a lot of practices. Sorry if I've missed anyone out. But I think we've got a really good offer locally in terms of provision. Laura and then Rima.
Hiya, yeah, I just asked a question before. I wondered if there was an update about the 7-day access appointments split via PCN. So I think it's been delayed, but I just wondered what's happening with that at the moment.
Yeah, we plan, Laura, to bring in some tight changes for the beginning of the new year. So we weren't planning to do it this side of the seasonal break. But you're right that some of the technology, basically we were hoping the technology would allow us to do it all from sort of day one in the new year. That's not going to be the case. So what we're going to do is roll it out on a phased basis. But I'm happy to provide you and colleagues with a little note of how. So, who's in January, who's in February, and that's the way in which we'll be taking it forward. But we will be also writing out to practices each week in terms of the allocations that they've used, so that hopefully practices will have a much clearer idea of where they are in terms of their expected use and their actual use.
Thank you.
And Sheeta just asking if we can still send the LVS details to the local pharmacies as well. So that's about communication.
Yes.
Rima, you had your hand up earlier.
Yeah, apologies, Nadeem, I've taken it down. I don't need to add anything, thanks.
And Wax, is there a webinar in a couple of weeks' time? Have you got one this month for your health and social care one?
You mean what, with the residents or practice council?
Friday webinars.
Practice council is
practice council next Friday. Yeah,
Next Friday.
Absolutely.
Okay,
I mean,
I wasn't sure because 2 weeks' time I think is a bank holiday. That's why I was asking. Any AOBs? If
2
not,
weeks' time is not a bank
Christmas
holiday,
Eve.
but scarily it's Christmas Eve.
It's Christmas Eve.
Okay, so the bank holidays come the week after.
Yeah, no, we've gone for a council next week because I think there's some things that we need to clear up before we enter into the festive period. We'll keep it short, but just a point there where practices can get some extra support as well and ask some questions and raise concerns.
Okay. All right, so we'll see you all next week then. Bye.
Thanks, Nadeem. Thanks, Karen.
Bye-bye.
We're on time, Nadeem. Is he gone?
He's gone. He went quick.
He's gone. That's right. I'll catch up with him.